On today's episode of the Dr. Mollie James Show, we have Dr. Kim Biss. She is an OB-GYN of Florida who has opened our eyes to what is happening with women's health after the COVID shots and COVID, including infertility, miscarriages, and we even get into hormones. So stay tuned for Dr. Kim Biss. Good morning, Dr. Kim Biss. Welcome to the Dr. Mollie James Show. I'm so honored to have you here. You were an absolute warrior during COVID. That's where we met. Give people a little bit of your background. You were an OB-GYN in Florida, and you were on the right side of things.
Yeah, sure. So I trained in the Northeast, but slowly got tired of winter. So moved down south and trained in St. Petersburg, Florida, and graduated residency in '98. I've been in private practice here ever since. Mainly boots on the ground. I'm not, in academic medicine. I never had any published papers or written any books, but, I could still keep track and notice trends of things. And I was really shocked that they ever were going to consider giving the COVID injections to pregnant women because we had no studies on them and we never give pregnant women anything fresh out of the box. And when they started the rollout, we not only noticed some problems with women's menstrual periods, but I slowly started to notice that my miscarriage rates had started to, trickle up. And then I started to track some other things during pregnancy. But, the other reason why I didn't see why we're going to give these women these injections is because in 2020, our pregnant women did well. I mean, yes, some got sick, but I never ended up with a patient in the hospital on a ventilator in 2020. That didn't happen till after the vaccines rolled out. So, it's just been, I think, a travesty that we ever contemplated the idea and then actually provided these women these injections because now we're seeing some not very good things.
And isn't it true that women have, when they're pregnant, they have a little bit of a blunted immune system? So they were actually in a prime position to not ramp up into that cytokine storm and what really made people sick.
There's that, and then the other thing is, we're always taught that as obstetricians that women have a suppressed immune system, so they're more likely to get sick, right? And I think that's the shtick to get all these women injected with flu vaccines for many, many decades. But I will tell you, in 30 years, and I have a very, wide range of patient types and ethnicities and comorbidities, and I don't have sick patients. I mean, I've taken care of probably 8,000 pregnant women in the course of my career. I've never had one die of the flu. I think there is suppression, but I also think there's something stronger in pregnant women. They don't get sick,
Uh-huh.
you know?
Yeah,
So,
that's awesome. So
mhm.
there's really some late breaking news right now that there's a physician who wrote the New England Journal article
Mhm.
they're really saying it should be brought up on criminal charges for suppressing information. Can we get into that a little bit? Can you explain what's going
Yeah, yeah, they're actually, part of my slide deck, slide 26, shows a picture of the Tom Shimabukuro article that was published in the New England Journal of Medicine in June of 2021. And that author is the head of vaccine safety, or was at the time. And many of the other authors on that paper were actually employed by the CDC or some government entity. And they were looking at the VSafe data, and they published this paper saying, oh, goody, these are safe in pregnancy because the miscarriage rate was normal, in air quotes, at 13%, which a normal miscarriage rate is actually 5 to 6%.
Mhm,
And not only that, but he didn't perform the correct math because they looked at the whole cohort of patients, which were, I think, 800 and some odd patients. But when you're calculating a miscarriage rate, you can't include patients that are beyond 20 weeks in gestation. So somebody actually read this article critically, not just the abstract, like most physicians do. And I must say, I'm guilty of that myself because how much time do we have to read these journals? And we figure peer review is exactly that.
yes.
But somebody read the article critically and looked at one of the tables and said, well, wait a minute, there were only 127 patients that would have fit the criteria for a pregnancy loss prior to 27 or 20 weeks. And if you use that as the denominator, the miscarriage rate was actually 82%. Now, the problem, and I'll show you in my timeline slide, the problem is that the American College of Obstetricians and Gynecologists and the Society for Maternal Fetal Medicine, which is the high risk OB society, used this article to then say the very next month in July that these were safe in pregnancy and we need to inject all our patients that are thinking of getting pregnant, or breastfeeding. I actually got in an argument with my high risk OB when this article came out, and he actually has another degree in statistics, and even he didn't read the article critically enough. And he said to me that these are safe and you need to be giving these to your patients. But this is the first of two slides that I just want to point out the timeline of how these, ended up getting approved for pregnant women. So we all need to go in the Wayback Machine in 2020 when Pfizer was doing their trial, which is what the emergency use authorization was granted based upon this data. And, Tony Fauci got up on stage at the end of December when these results came out saying that these were 95% effective at preventing COVID, which he was using the relative risk statistic, not the absolute risk reduction, which for the people who are listening to this, the absolute risk reduction means, doctor, if I take this injection, how much am I preventing myself from getting the disease or the illness? And it wasn't even a percent. I mean, minor symptoms, it was 0.84%, but major symptoms, it wasn't even 0.1%. So your prevention was minimal. And there were no pregnant women in that trial. Men were told to abstain from intercourse. And if you did have sex, you need to wear 2 condoms and be sure the woman's on some form of birth control. So clearly didn't want any pregnancies. And I'm sure there were some accidental pregnancies in this trial, but I don't have that data. I'm sure it's not very reassuring.
Yeah.
If you go to the next slide,
Uh-huh.
so what ended up happening was there was a rollout to certain groups of people with these injections. So the end of December, early January was the first responders. Well, some of those were women, and the Pfizer aftermarket data was published the end of the next month in February, which most of the public didn't have access to. Naomi Wolf and her colleagues really dug down into the Pfizer data. But Rochelle Walensky had this information. She was the head of our CDC at the time. And if you look at the numbers I've highlighted, clearly not very reassuring. They had 270 pregnancies, of which they only followed up on 32 patients. You would have thought they would have been white on rice and followed up on everybody because they didn't want anybody getting pregnant. But they only followed up on 32, and 26 of them miscarried. So similar statistics to the New England Journal article. But the very next month, or in April rather, she did a interview with at the time, Eric Rubin, who was the editor of New England Journal of Medicine. And she stated in that interview that these were safe and effective in pregnant women. Based on what? We had no data supporting that. If anything, we had negative information. Then the article that I talked about in June came out. And then prior to that, however, we have come to find out through Jim Thorpe, his wife Maggie's an attorney, filed a FOIA, realized and found out that HHS had been funneling money into several trusts, out of which the media, Hollywood, sports entities, medical associations got money to market these injections. And ACOG got somewhere in the range of 11 to $13 million in April of 2021 to market these injections to women, which is a great tactic because, as you and I know, most of the medical decision making is made by women. And again, if you can take a pregnant woman to take an injection, game over, just like the first responders in January. They don't care about the first responders. But if a doctor or a nurse takes an injection, then the lay public will follow. And they had the same rationale with women. So the article comes out in June. Then July, our societies tell us this is a great thing to give to your pregnant women. And the statement is still, if you go onto ACOG today, they still recommend that you provide these injections to all your patients. 5 years later, with all the negative data.
Yeah. And the next point on your slide, I think, is mind-blowing.
Yeah.
Yeah.
Yeah. I mean, Comirnaty, Moderna product, any of these products, they have this clause in the package insert. And I will tell you, the majority of flu vaccines, even though we've been giving flu vaccinations for over 3 decades now,
Uh-huh.
they also claim this. And yet we give that to pregnant women. And if you're pregnant and you span 2 flu seasons, we're supposed to give you 2 flu vaccines.
Oh, geez.
Mhm.
Yeah. And like you said, one of the most important things when you're making these tough decisions is what is my actual risk of illness? And if you say in your entire career you've never seen a woman get sick enough from the flu that it impacted pregnancy or she died,
Correct.
that's a lot of
Correct.
effort for not a lot of win.
Yeah, there's a lot of risk. Nobody received informed consent, right? Because we just said safe and effective, and nobody qualified for an exemption. I mean, it was
Uh-huh.
crazy because you had to be allergic to this. Well, how you know you have an allergy? These are freshly out on the market. So, yeah, I mean, in 2020, we had, if you want to show my next slide with my data on slide 27,
Hmm.
um, so the story behind this is that I was kind of loosely monitoring things, but didn't really drill down into my electronic record until 2022. But in the fall of 2021, in November, my office biller came up to me, and she's not clinical at all. She just does her billing. And she said, Dr. Biss, we've had a really high number of miscarriages this month. We've had 8, which for my practice, which is small, we deliver 300 babies a year. Okay. So if you're getting 20 to 30 new OB patients in a month, to have 8 losses, that's a huge number.
Yep.
So I decided to start loosely tracking, but then in the fall of 2022, Steve Kirsch did a video that went viral of me discussing my miscarriage rate. When I went home, my husband said, well, you better be sure that you're correct in that. So I went back to 2020 in January and went through all the new OB entries into our practice in the first trimester, which is what the blue bars demonstrate in this picture. I also tracked the number of deliveries and the number of miscarriages. And I will tell you, in 2020, we had the best newly entered number of patients, the lowest miscarriage rate of 4% on average month to month, and the highest number of deliveries we've had to date um, because of the lockdowns, wink, wink, because people, so we had a lot of Rona babies in November and December of that year, but we've yet to reach that number of deliveries. I tracked all this data. I sent it to Jessica Rose. She has it published in her Substack, which I encourage everybody to follow her. She's brilliant.
Uh-huh.
But if you notice, going to the next year and the year after that, the number of people newly pregnant entering into the practice is going down. And the number of miscarriages, I said in my video with Steve Kirsch, went up 50%. I was incorrect. It actually went up 100% from year to year. Now, November of 2021 was high, probably because that was when people were getting boosters. But the average went up. It doubled in 2021, and then in 2022 it doubled again. And that data was up till November of 2022. In December of that year, we had a 27% miscarriage rate. And then in January and February of 2023, it was 30%. And then it started declining back to normal, which today I would say it's normal. What's concerning is I also tracked how many patients in my practice got these injections, and it was about 65 to 70%. The majority had 3 injections total, very few had 4 or more. 80% were Pfizer, the remainder were Moderna, and I had a handful of J&J. So most of my patients received their injections in the early portion of 2021 and then got their boosters. And yet, we were still seeing effects in 2022 and then in 2023. Now, the blue bars going down is probably not only a reflection of women miscarrying before they even make an appointment, but infertility. We did have patients, we had no problems with them, delivering prior, getting pregnant on their own prior. Now, all of a sudden, they need in vitro fertilization. And you will have obstetricians say, well, I didn't see any increase in my miscarriage rate. But the problem is, most obstetric practices, there's no solo obstetrician. because nobody's going to be on call 24/7, 365. So you're
Right.
usually in a group. You share the patients, meaning they rotate, they see a different doctor every time they come to the practice. So unless you're going into your EMR and tracking this, you're not going to notice an increase because you might not have seen any patients that have miscarried, but maybe your partner had three. You wouldn't know. So you don't see what you're not looking for. And not only does my data show it, but it's clearly in the VAERS data and some other systems that other countries utilize to track, their miscarriages and stillbirth rates.
So, knowing this is the case, have we seen any government entities now come out and retract this and say this caused massive problems? We don't recommend pregnant women get this. Have we seen any correction from any professional societies or organizations?
No, as a matter of fact, the a letter to the editor was written to the New England Journal regarding that article, saying, your math was wrong, and they said thank you for your inquiry, but they've yet to retract the article. If you go on that link, you can still pull it up.
Yeah.
Um, ACOG has not changed their stance, probably because they got money, right? They'd have to pay it back and then some. But no, there's been no professional organization that has retracted anything. And I mean, clearly the data is out there. I mean, there's thousands of articles now showing harm with a menagerie of organ systems in the body. I mean, the first was the myocarditis, but I will tell you informally, what came out very early on was women having issues with their menstrual periods, and that was, poo pooed. But, that's how we work, right? If our menstrual system or cycles are not happening correctly, of course that's going to affect pregnancy and fertility. I mean, that's how we roll. So, that was shunned very early on. So, no, to my knowledge, and hopefully that'll change with, the new people that are in the entities in Washington and in Atlanta now, but, that remains to be seen.
Yeah, so you bring up an interesting point, which is that women were raising the red flags on this very early. Something is wrong. And I know specific communities like the uh, Jewish communities
Uh-huh.
said, we're not doing this because their whole society revolves around the women's fertility, around their periods.
Exactly. Like there was a huge uh, community in New York
Mhm.
that just came right out and said, "We're not doing these injections," because they started noticing a problem. And then, of
Yeah.
course, they were shunned because, they were gonna, cause the death of everybody around them because they weren't getting the injection.
Yeah, exactly. But I think this brings up a bigger problem in medicine. And I had a patient in my office tell me one time, she said, if I go to the doctor and I don't have my wedding ring on, I'm totally dismissed. No one listens to me. If I wear my wedding ring, they'll listen to me, but I'm not taken seriously. But if I bring my husband to the appointment, all of a sudden what I'm saying sticks. And I
Wow.
thought that was a really powerful observation that I do think women's concerns about their own health are dismissed a lot just in our society and the way, not us specifically, but
Sure.
the way medicine is practiced in general.
Right. Well, medicine is based on the 70-kilogram male, right? Most of and I joke with my patients because, uh, the American Geriatric Society is primarily men. I'm sure, because they deem women shouldn't be on hormone replacement therapy. It's dangerous, and yet they're giving 90-year-old men Viagra. So my patients are home with old lady vagina, no interest in sex, and their husbands are coming home with erections because their doctors are giving them this medicine. It's like we need to have balance here, people.
Need some balance. That is correct. I want to get back to your point about hormone therapy, but you had pointed out a couple more slides. So I wanted to give you a chance to talk about these.
Sure.
Um, this is a study you did with Dr. James Thorpe, who actually is going to be on with us soon.
Oh,
Uh,
great.
so tell us a little bit about this study and this slide, and then I think there's one more as well, or a couple more.
Yeah, so this paper actually is published, peer-reviewed journal as of 2 months ago, but the authors on here are amazing. I mean, two of the authors, Albert and Julie, are really adept at digging down into the VAERS data and finding hidden data, actually. But what this study looked at was 35 pregnancy adverse events that were reported in the VAERS system. And we had 3 separate groups. We had 40 months of the COVID injections. We had 412 months, because this goes back to when the VAERS system started in the 90s, of influenza vaccines. And then the third group was all vaccines going back 412 months, because there are some other vaccines that pregnant women get, Tdap being an example, but they may get some vaccines if they have to travel to another country. So if you go to the next slide, this is a table that shows those groups broken down. So if you go into the upper left miscarriage box, so the first number is in 40 months of COVID injections, almost 3,500 women reported a miscarriage. The middle column is for flu vaccines going back to when we started giving them to pregnant women. And then the final number is all vaccines going back to 1990. So if you do reporting ratios, if you go to the next slide, the reporting ratio for miscarriage, the proportional reporting ratio in the middle top, the 114 number, means if you get a COVID vaccine, you're 114 times more likely to miscarry than if you get a flu vaccine. We based everything on the flu vaccine because they're supposed to be safe in pregnancy. Okay. Now, a PRR greater than 2 is supposed to raise a red flag with the CDC. This is their own reporting system, theirs, which they always say is, doesn't function properly. Well, it doesn't function properly because, one, it's underreported, and two, shenanigans go on behind the scenes to erase data. But even so, this is clearly greater than 2 and should have raised alarm. I mean, the number for menstrual abnormalities went through the roof. That number was way larger than 2, and nobody took a look at that. I mean, there were a lot of Houston, we have a problem here, red flags raised, never investigated. These should have been halted right away when Walensky had that, those numbers from the post-marketing data. They should have halted them and said, well, wait a minute, what are we doing here? Yeah.
Absolutely. Um, so tell me now, have the period irregularities that women saw, have those calmed down? Just like you said, the miscarriage rate has now corrected back to normal. Are we seeing that improve, or are there women still out there struggling with this? And what do they do?
So I would say they've improved. I don't deliver anymore, but I'm close enough to the ultrasound suite, and I kind of hear through the grapevine if there's a miscarriage or whatnot. And I would have to say that's normalized. What I am seeing now, which is pretty interesting, is that fibroids have increased, all of a sudden growing in women that never had any problem, growing rapidly. Fibroids the most common reason we do hysterectomies. I did 3 yesterday, by the way. Endometriosis in some patients tended to be exacerbated after these injections. My abnormal pap smear rate has gone up by 15%. I mean, women that have had the Gardasil series, don't even get me started on that, but they're coming in with abnormal paps. And I'm doing an incredible number of leaps on people for, persistent abnormal pap smears. And I believe that's because the HPV virus has been reactivated. Just like, if you recall, a lot of people in the beginning, when they got these injections, they broke out in shingles, which is the reactivation of varicella. So I'm doing annual pap smears on all my patients, even though the current guidelines are to do them every 3 to 5 years. Um, Breast cancer, sadly, through the roof. My local breast cancer surgeon, who's one of us, by the way, and we just realized that last fall. I'm like, where have you been my whole life? We're like these little islands finding each other.
Uh-huh.
Um, she said, sadly, her breast cancer rates have increased in under 50 and by 30%, and bilateral breast cancers upon presentation have increased remarkably, and that's not normal. I had a patient, sadly, she asked me if she should get the injections in 2021. I told her no, I didn't recommend these to any of my patients, pregnant or not.
Uh-huh.
She got 2 Pfizer. The next month, had bilateral breast cancer diagnosis, went to Moffitt Cancer Center here in Tampa, which recommended all the boosters. So after her 3rd booster, now she has a brain metastasis, which is not common in breast cancer. I saw her for her annual exam last spring after her craniotomy for her mass in her brain. And she said to me, she said, "You know what, Dr. Biss, you were right. I shouldn't have gotten these shots." And I said to her, "I don't want to be right. I don't want to be vindicated. I think this is criminal."
I have to ask, why are they doing a craniotomy for metastatic breast cancer? I've never seen anyone do that. Now, primary brain tumors, maybe, but a metastatic lesion? Doing a
Maybe,
craniotomy?
maybe they didn't think it was a metastasis. Yeah, because that's not common.
So the theme here is squashing the immune system is a bad idea.
Uh-huh. Uh-huh.
And I think, probably people listening to this understand, they get it because they're like minded. That IgG4 class switch, when
Uh-huh.
we switch to tolerance, when we keep exposing ourselves to the same antigen, it
Uh-huh.
shuts up your immune system and that creates a host of problems. We see it in our chronic Lyme patients,
Uh-huh.
we see it in people with Epstein Barr. So, same thing, HPV reactivated, your cancers are coming back because your immune system can handle those.
Right.
Our immune systems fight cancer every day, right?
Right. Right.
And so, yeah.
Yeah, and I mean, my staff, I can't recall having a full week of a full complement of staff in my office. They're always sick. Now, I'm in Florida. We don't have a flu season, okay? We had 5 people out of my office 3 weeks ago with the flu. I mean, in bed sick. 1 tested positive for COVID, which I don't even know why you're testing, but anyway, you know, they're always sick. I'm the only one in my office that hasn't been, injected with these things.
Uh-huh.
And the other thing with these injections, yes, they overstimulate the immune system, so the IgG4 is increased. But we know that the spike protein also blocks some cancer pathways all by itself. And there is also some data showing may interfere with the BRCA genes, which we all have BRCA genes. Everybody knows Angelina Jolie is the most famous one, but it's not that she has the genes, it's that she has a defect in those genes. Those are genes that prevent us from getting cancer. And
Uh-huh.
we find that the spike protein is inhibiting those genes from working. So there's a menagerie of ways that people are ending up with these malignancies. I was talking to a neurosurgeon the other day who I think is kind of sort of leaning towards our side, but he works at Moffitt. And I said, he said, yeah, we're seeing an increased number of glioblastomas of late in younger people. And I said, "Well, why do you think that is?" Hoping he was going to say something about the shots, and he didn't. He said, "Well, the water table in Florida is really shallow, so we think it's due to the pesticides in the water." Which,
Might be both.
okay, but I'm
Yeah.
sure the water table didn't change dramatically in the last 3 years,
Yes.
you know?
I'm
So,
really concerned about the use of AirPods. I see yours are
mhm,
wired. You
yeah,
know, so many people now are using those AirPods and they don't realize that frequency that you're putting right next to your brain.
mhm.
So I've switched totally to the wired unless I'm working out. And that's just, a short time, a few times a week.
Yeah, I agree, and I anymore, I'll put my phone on speaker. Like, I
Uh-huh.
don't hold it
Don't
up to
hold it
my
up.
head because
Yeah.
you just don't know, and these phones get stronger and stronger. I mean, just you don't have an idea of how much what it's doing. So,
Yeah. Yeah. So, again, are there women out there that are still having issues with their periods? And did you find a solution for that? Is ivermectin the answer for those patients? Like, how were those approached?
so we I'm in a study group, abrg.org, Advanced Biologic Research Group with Dr. Thorpe, Dr. Dan McDyer, Ryan Cole, Dr. Stephen Hatfill. Um, we have been trying to get a study done. We finally got IRB approval But now we need to get funding because, of course, we're going across, we're going against the narrative. So who's going to give us money? We're self-funding a lot of this, but we're going to do a pilot study with 50 women's tissue blocks because if you have surgery, the lab has to keep your tissue block for 10 years, and any other lab can request that and do study on that. So we're going to look at women that have had either like DNCs for abnormal bleeding, hysterectomies for abnormal bleeding, and even placentas, because sadly, postpartum hemorrhaging increased as well in the last 3 years. And we want to stain those tissues for not only spike protein, but we have probes that can stain for vaccinated RNA.
Mm.
So, the problem is there's lots of people that have protocols for spike, but we need to actually know what's going on and how these tissues are being affected and where the problem is originating from. We theorize that the messenger RNA is getting into the endometrial lining, into the cells, and turning them into spike protein factories, which is going to create a lot of inflammation. And nothing good in pregnancy occurs with inflammation. So, if there's an inflammatory situation going on in the uterine cavity, there's not going to be implantation. Um, and then that may also explain why placentas have been found to have a lot of spike and messenger RNA in them. But we just, we're trying to get the research done. It's just there's not a lot of interest because it's not going to show very good things. So,
Yeah, it's
but
certainly.
ivermectin, yes, ivermectin helps. Um, Chlorine dioxide, which I'm nowhere near being an expert in, has seemed to help. Some of my colleagues have, that are in our movement have tried that.
Mhm.
And, trying to get the spike protein down, of course, with N-acetylcholine and some other things has been helpful. But,
Yeah.
everybody's different, as you found with vaccine injured patients. I mean, not everybody responds. But I must say, I mean, clinically, I'm not really seeing a lot of that anymore, thank God.
Good. Yeah. Let's jump over to another area of medicine, women's health, that you kind of touched on, which is women's hormones.
Mhm.
This is such a hot button. And, on the men's side of things, there was a published study that said testosterone increases the cardiac events in men. And so everyone
Mhm.
backed off of testosterone therapy thinking it caused heart attacks.
Mhm.
And what they didn't get is the retraction, which is that they flipped the data. And the
Mhm.
patients on testosterone actually had a lower incidence of cardiac events.
Correct.
Women are even more complicated on this spectrum because you have more
Sure.
hormones going on. So, give us the breakdown of where we are with that. And then, especially in light of a skyrocketing incidence of breast cancer in patients in
Right.
this changing post COVID environment, what is your recommendation to most of your patients?
Well, let's go back to prior to COVID and these injections. The Women's Health Initiative trial that came out in 2002, which was actually done by cardiologists, not gynecologists, and scared every woman in the planet with regards to taking hormones because they showed, and they primarily looked at Premarin and Provera, which is the estrogen and the progestin, and they found that women were more likely to have heart attacks, breast cancer, colon cancers, and I forget what else they followed. But, within the last year, they've now come out saying that a lot of that data was fudged as well. Um, I've always been a proponent for hormone therapy. I feel like I tell my patients, there are mammals in the mammalian kingdom that once they can't reproduce anymore, they die. Okay. Well, we're living almost 50 years beyond our reproductive capacity, and you have to weigh risk and quality of life, and I don't believe that estrogen causes breast cancer because if it did, every woman walking on the planet would get it, right? Because we're all making our own hormones on average for 52 years. There has to be something, and obviously it's multifactorial because we still haven't made a dent in breast cancer. If anything, it goes up year to year. We haven't really decreased the incidence, and now it's younger and younger.
Yeah.
Has to be something environmental. It's not genetic. The majority of breast cancers are what we call sporadic, meaning no family history. So I still advise patients if they want to go on hormones, I do that. I have a patient, she's 73, recently diagnosed with breast cancer. She had the surgery. They offered chemo. She said, absolutely no way. I'm not taking chemo because I've seen a bunch of my family members die after they got chemo. She came to me and she said, look, I'm 73. I have a very good sexual relationship with my husband. I've been on hormones for 40 years. I don't want to go off my hormones. And I
I love
said, well, you realize you might be at increased risk of a recurrence. And she's like, I don't care. So I had her sign a thing and I'm giving her hormones.
Yeah.
I think it's up to the patient. But if she goes to her oncologist and says, "Well, I'm on hormone therapy," she'll be fired from that practice because she's taking hormones.
Not only will she be fired, that oncologist will probably report you to the Board of Medicine for violating standard of care.
Probably.
In this hostile society today.
Yes.
Yeah.
Yes.
And what I'm seeing on the breast cancer side of it, I used to have a busy breast surgery practice. And so, this is 10, 12 years ago that I was doing these conversations every day. And these early stage breast cancers, if you've got a cancer the size of a pea, we're cutting it out, we're getting a path report, and now we're deciding probably do radiation, maybe do chemotherapy. And I've
Mhm.
just come in with a stage 1 tiny breast cancer, and they're getting 6, 12 rounds of chemotherapy and then radiation and then surgery, and I'm appalled at how many I see coming back 2 to 3 years later that are now have recurrence, and they're just shocked. I'm like,
Mhm.
"Well, you have a recurrence, you've had tumors in your breast, and then you've had all this chemotherapy that suppressed your immune system."
Mhm.
So, to your point that we haven't really made a dent in breast cancer, I feel like what we've done is we've improved the business model of it because we're
Mhm.
diagnosing early breast cancer, we're putting people through hundreds of thousands of dollars of treatment, now
Mhm.
probably more than one time.
Well, not only that, and again, prior to 2020, none of this would have come out of my mouth. But I think 2020 and COVID was a blessing for a lot of us because it really opened the drapes to how much of medicine is complete BS.
Yeah.
And it's driven by money. It's not driven by patient outcome. Show me an oncologist that doesn't live in a mansion. I mean, chemotherapy is very lucrative and it doesn't cure a lot. I mean, they say it puts people in remission, but
I think 20% effectiveness is the best I've heard.
yeah.
20% of the time it does something positive.
And that depends on the cancer you're talking about.
Yes.
But even mammography, I mean, how many mammograms do you have to do to save one person's life from cancer? But how much cancer are we maybe causing by exposing women to the radiation, which of course they say is safe, but you have somebody now because of the legalities now. I mean, there's things that radiologists, quite frankly, 15, 20 years ago would not even have called on a mammogram. But now, because so many have been sued, every little speck they see warrants a follow up, which is more radiation. And then you're going to get a biopsy, which maybe poking something and making it burst is not a good thing either. I mean, who knows?
Uh-huh.
Um, so what are we doing with mammography even? And I think, a lot of my patients, which I used to call cuckoo for, Cocoa Puffs prior are getting thermograms, but let's look at some other interventions. I mean, obviously the MRI is probably the best, but that can't be a screening test because it's very expensive. And plus you have to get IV contrast in order to get that, and you might hurt your kidneys. So we need to find something. And the other thing I've read is that, women can die, especially DCIS, right? Ductal carcinoma in situ. Women can die with that. They're not necessarily going to die because of it,
Yes.
you know?
Yes. I have people coming to my office with DCIS and undergoing these aggressive treatments, and I'm like, "Let's put this back into perspective here. What
Mhm.
you have a precancerous lesion." And, and this is what I tell my patients also, is you have to assume the risk here. They
Mhm.
have these recommendations, but what I don't want is if you choose not to get a mammogram for 3 to 5 years, you don't go sue the radiologist if they find something. You assume that risk. And I think
Mhm.
that's a huge part of it is, I tell them their job is to never ever miss a cancer ever, not one time. And so they're going to overcall everything to your point. You're going to have more biopsies, more scans, then they have people on the every 6-month
Mhm.
track because you're high risk. They've
Mhm.
medicalized life. Go live your life.
Right. Right. Yeah, it's incredibly anxiety provoking in patients. Every time they go and get a study
Mhm.
and, they're worried. And I mean, what does that do? What does all that anxiety and stress do for people, too? I mean, there's a lot of things we need to kind of rethink how we're doing, but money drives everything. So it's crazy.
Yeah. What is your thought? I'm going to label you maybe a new addition to like the Maha movement, kind of
Hmm.
went from that traditional, which most of us did, into more of a eyes wide open practice. Where do you see the future of this going? You're an IMA senior fellow as well. You're on the cusp of trying to open up the public's eyes to the truth. Where do you see this going?
Yeah, I'm hoping there's going to be a lot of change from the top down, but I think there has to be a lot of change from the bottom up too. I think that we all as physicians need to stop being, Western medicine snobs and realize that there's other ways to skin a cat. Eastern medicine's been around a lot longer than Western medicine. And I'm not saying to do those things in lieu of what we do, but certainly they may be, synergistic or if the patient, has tried everything in Western medicine, who cares? I used to be one of those snobs, but I'm not anymore. Um, I think too that we need to stop financially incentivizing a lot of what happens in medicine. I mean, we get rewarded by insurance companies for checking boxes in an EMR. Internal medicine, make sure you have a certain number of people on statins, which that's a whole podcast in and of itself. The pediatricians are incentivized to have a certain number of their kids on the vaccine schedule. We need to get rid of that model. And we also, I feel, we don't come off assembly lines. A lot of patient safety and hospital safety is modeled after the airline industry and standardization, which I'm not saying some of that is not is good, but you know, even the airline industry of late is not stellar. Plane doors coming off planes mid-flight, but anyway, um, we're not all the same. We're not built the same. There's different ways to skin a cat, and COVID just took all that away. I mean, you used to be able to, if you had a patient in the hospital, you wanted to try something new, you called your colleague around the world. He said, yeah, there's this paper in this journal. You would print the paper, put it on the patient's chart, justify in your note why you're doing this treatment on this patient, and you were fine. Well, then COVID happens. Oh my God, you want to give somebody ivermectin. Now you're going through peer review and they're kicking you off staff. I
Mhm,
mean, and those protocols are coming from the top down. It's the administrators that are deciding this because the government, entities above them are telling them this.
mhm,
It's awful. The whole corporatization of medicine
mhm,
is awful. And if you look at the patient outcomes in the United States of America, we fall very low down on the list of other countries. We are not a healthy population. And people blame that on our lifestyles, which that is part of it. But it's also when you go to the hospital, what they do to you. Now you show up sick. You're usually admitted to the hospital because you're sick. They're giving you flu shots and all kind of immunizations the day you're admitted just to check a box in the EMR. And you and I were always taught you don't give somebody who's sick a vaccine.
they did this to my ICU admissions. Went off the handle even before I became an activist on a rational use of vaccines.
Mhm. Yeah, and then they don't want to give vitamin C and vitamin D. I mean, but they give all these other things that are much more harmful and usually not helpful. It's just if you can stay out of the hospital, unless you have a hot appendix or a broken bone, I think you're good.
Very good. I think a lot of people out there probably resonate with a lot of what you're saying and they want more Dr. Biss. So, where can they follow you? Where can they find you? And maybe even support your research?
Yeah, so the only social media I'm really active on is Twitter or X. So I'm at DocBiss, DocBiss. I do have an Instagram page, but I really just follow animals on there. Um, And
Basic.
my research group is abrg.org. So if you're inclined to go on there, that would be great. We are trying to, do some fundraising as well. And hopefully with, Bhattacharya now, the NIH, they'll start giving out grants to people who really want to do some good research. So.
Yeah, perfect. As we wrap up today, if there's a young lady that comes to your office that's navigating all of this world of I want to have a baby and I want to get aged gracefully, what would be kind of your 1, 2, or 3 points of advice to women out there navigating?
Yeah, I give all my GYN patients a little packet of information, and on one of the sheets is talks about eating healthy. Obviously, I mean I've been ketogenic, almost carnivore now since 2018. I intermittently fast. I recommend that to all my patients. Obviously, avoid anything in the middle of the grocery store because if it doesn't look like food, don't eat it. Try to grow your own food. Know where your food comes from, but obviously exercise, getting good sleep. Um, but a lot of them come to me now because they're concerned because either they've had the injections or their partners had the injections, or even being around other people because you and I know they're shedding and they may have been exposed to it that way. So I do talk about some of the spike things they can try. Baobab fruit I've learned about, which is a powder. It's from the tree of life, they call it, but it's a powder you put in your water and sip it all day. And that has a lot of benefits, one of which it gets rid of spike, but it also has almost like a aspirin a day effect, which, preventing blood clotting, which might be the cause in some of these women as well with the miscarriages is microclotting in the uterus. So that's pretty much my spiel, and I do support vitamin D, K2, magnesium as well to not only keep up your immune system, but that also helps with keeping up your bone density. And like we've already talked about, I do advocate hormones for hormones, and I do give hormone pellets, but I also do creams and other routes. So
Wonderful. Well, thank you. This has been a great discussion. You opened my eyes to even a few things. So thank you for spending time with us today. I really appreciate it.
thanks for having me.
Yep. Tune in next time to an episode of the Dr. Mollie James Show.